So I saw in central monitor that patient is having AF. I went at the patient and there was AF with fast ventricular rate with hemodynamic stability. The patient was not a known case of AF. So it is AF with of less than 48 hour with hemodynamic stability. So we can give rate control as well as rhythm conversion drugs. Pulse, the RR wave on ECG, RR interval will be irregular. Absent of P wave, we will have fibrillated instead of P wave. And in flutter, there can be, if there is a block of 1:2, 2:1, or 4:1, or 1:1. So in that case, it could be the rate may not, RR may be equal, but there will be sawtooth P waves. Instead of P wave, there will be sawtooth wave, like this. And there could be flutter fibrillated wave also. So accordingly, so if it is there is no fast ventricular rate, then there is no need to manage immediately. But if there is a fast ventricular rate along with the atrial fibrillation or atrial flutter, we need to manage it. So how to manage? First, we have to see whether the patient is stable or unstable. So hemodynamics, we have to see. Unstable, synchronize cardioversion. Even if you don't have time, you can do direct cardioversion without synchronization. If there is patient is so unstable that, or maybe patient is going into arrest or something like that, then in that case you may go for without synchronize. You can just do cardioversion. Otherwise, synchronize cardioversion. In any shock, unstable arrhythmia, you have to do cardioversion basically. And if it is ventricular fibrillation or pulseless VFVT, you have to go for defib. So if the patient is stable, rule out WPW. Delta wave will be there. So there will be delta wave if you have WPW. Broad QRS complex, broad QRS with delta wave. Sliding of upstroke of QRS interval. So if it is that, we can't give AV. So you can't give AV node blocking agent. What are the AV node blocking agent? It is, I have remembered as A, B, C, D. Adenosine, beta blocker, calcium channel blocker, digoxin. So if the patient is stable, now you have to see whether this arrhythmia is greater than 48 hour or less than 48 hour. So if less than equal to 48 hour, you can control the rate as well as you can convert the rhythm. But if it is greater than 48 hour, do not convert rhythm until you give anticoagulant. Until anticoagulation is given for 3 weeks before, and then you can do cardioversion, and then you can give another 4 weeks of anticoagulant. Okay. So but if it is less than 48 hours, or the patient is already anticoagulated, this thing has been done, or since even before the patient might be on dabigatran or warfarin, or according to the Chaddack VAS score and has bleed score. So then you can go with anticoagulation. You can go with antiarrhythmic agent as well, even in greater than 48 hours of AF. So less than 48 hours, or greater than 48 hour. Both things, just you have to remember this, that do not convert rhythm until anticoagulation is given for 3 weeks before, and then you can do cardioversion. That is, you can give antiarrhythmic agent for converting the rate, and then you for another 4 weeks you have to give anticoagulant. So what are the, if it is less than 48 hour or greater than 48 hour, other than this, the things are common. You have to do rate control first step, and then you go for rhythm conversion, then you go for rhythm conversion. This is second step. So rate control, for rate control or rhythm control, you have to see whether the patient's heart ejection, left ventricular ejection fraction is normal or reduced. So if a normal, preserved the EF or reduced EF less than 40% suppose. So preserve EF, you can give metolar or any beta or beta blockers. For others, for reduce, you can't give. So deltiazem, digoxin or amiodarone you can give for rate control in both case, in reduced ejection fraction or in preserved ejection fraction. So this can be given here also. Okay, same way, even for the greater than 48 hour also, you can give, same thing can be done, same, but avoid anti-arrhythmic agents. So why? If it will convert the rhythm, then there is a chances of embolic stroke. So we have to anticoagulate, and then only we give anti-arrhythmic agent if the AF is of greater than 48 hours. So digoxin, amiodarone, these should be avoided, or any anti-arrhythmic agent should be avoided if the AF is of greater than 48 hours. So rhythm control as in either case, preserve ejection fraction or reduce ejection fraction, amiodarone can be used. For preserved ejection fraction, we have much more options, like we can give propafenone, or flecainide, or we can give procainide, or ibutilide. This amiodarone is class 3 agent, and same ibutilide is also class 3 agent. Just for a reminder, procainamide is class 1A, and these two are class 1C agents. Where there is F, that is class 1C agents. So for reduce, you have only these options. Same thing for here also, same, but anticoagulate before. So what you will do for anticoagulation? So if it is urgent, you have to start IV heparin, then do TE, no clot, in another, no clot, no clot, you can in another 24 hour you can do cardioversion either by medicine or by cardioversion by synchronized DC shock. And then you have to continue with anticoagulant for another 4 weeks. Anticoagulation you have to give. If not much emergency, not emergent, 3 weeks of anticoagulation, then rhythm control conversion either by medicine or by DC shock. Then again 4 weeks you have to continue anticoagulant, you have to continue. Since DC shock monophasic or biphasic, nowadays biphasic is done 100, 200, 300. Start with the lowest dose and accordingly you can go for further. Before this you must sedate the patient and give a painkiller, so that the main gist is that atrial fibrillation or atrial flutter you have to see for any arrhythmia, you have to see for hemodynamic instability. If it is unstable, you have to do synchronized cardioversion. If it is stable, then you see for whether it is less than 48 hour or more than 48 hour. If it is less than 48 hour, you can do rate control as well as rhythm conversion. But if it is more than 48 hour, so this is the thing, you do not convert the rhythm until you give anticoagulant 3 weeks before, and 4 weeks after the rhythm conversion you have to give anticoagulant. But in case suppose there is an emergent situation, you start with heparin, do transesophageal echo, see if there is no clot, and then in another 24 hours, if there is no clot, in another 24 hours you can do cardioversion, and then continue with another 4 weeks of anticoagulant. So then the rhythm conversion, as I have said, it can be done either by these drugs or by synchronized cardioversion. Synchronized cardioversion nowadays we go with biphasic only, and you have to start with the lower dose like 100 joule, 200 joule, then 300 joule, like that. Before that, give sedate the patient and give painkiller. And as I have told, you have to rule out in the beginning only any WPW. If there is WPW, don't give AV node blocking agents. Go for DC shock, synchronized cardioversion, or sotalol, amiodarone, procainide you can give. Thank you.